Okay.
Thank you, ladies and gentlemen who are joining us. We shall be starting in the next 2 minutes. Just giving a few minutes for people to join in. Thank you very much. Thank you to all who have joined us this evening. I am hoping Dr. Willis Ahwale is ready to share his screen. I will invite my co-host, Dr. Simon Kigondu, to start the meeting and invite Mr. President, Dr. Were, to make a few opening remarks. I am told our chief guest, Dr. Mercy Mungangi, is in the meeting and possibly invite her. Thank you.
Thank you to everyone who is tuned in to this meeting. We, as the Kenya Medical Association, have invited the Ministry of Health to give Kenyans an update on the COVID-19 vaccine. And with us today, we have the National Executive Council of the Kenya Medical Association, the chair of the Kenya Medical Practitioners and Dentist Council. We have Dr. Lois Ombajo, who is an infectious disease specialist, and we have Dr. Mbira Gikonyo, who is in charge of the Nairobi Hospital COVID-19 Task Force team. Our chief guest will be Dr. Mercy Mwangangi, and on this note, I want to invite the President of Kenya Medical Association, Dr. Were Onyino, to take the floor and kindly invite the CAS.
Thank you, Dr. Kigondu. I won't put on my video. I'm still, I'm en route to Nakuru. Apologies for that. CAS, Dr. Mercy Mwangangi, Dr. Ivan Jenga, the chair for Kenya Medical Practitioners and Dentists Board, all the panelists, all the national executive members for KMA, and all the guests and colleagues, I'd like to formally welcome you to this meeting where we're going to hear about the plans the Ministry of Health has in terms of rolling out the vaccination program that we have all been waiting for, so that to help in addressing the COVID pandemic that we are currently faced with. So we are very grateful to the Ministry of Health for taking this initiative to work with Kenya Medical Association in order to help disseminate this information. So without further ado, I'd like to officially welcome Dr. Mercy Mwangangi, CAS Health, Ministry of Health, who's been working very closely with us, and we really appreciate the support that is given to the fraternity in terms of ensuring that, especially this issue of the vaccines capsule friction. So Daktari, karibu, feel at home. We're ready to hear from you. Asante.
Thank you, Dr. Wera, and thank you to the KMA fraternity for giving us this opportunity to address you today. I must say that, it's important that I begin by really appreciating members of KMA for all the work that you've done, particularly last year. I think many of you know that a huge component of this response would not have been possible without the plug-in of the Kenya Medical Association, as well as the very important work that was done by the Kenya Medical Practitioners and Dentists Council through the chairmanship of Dr. Ivan Jenga. And so we thank you all. We would like to really take this opportunity to extend our gratitude to all the healthcare workers across the country for the work that you've done. Let me also say that, as we get into the vaccine discussion, it's important that we perhaps reflect particularly, on what the year 2020 has been and 2021. And just to, have those silent celebrations of the successes of 2020 and 2021, particularly when it comes to science, particularly when it comes to the practice of medicine. I think we've seen an elevation of our work. I think we've seen credibility return back to the healthcare sector. I think we've seen the voices of medics, doctors, all cadres amplified when it comes to the role that they play in ensuring economies and countries function. And so really that is something to reflect upon and to be grateful for. And so, as part of this process, as you're all aware, Kenya, has participated in the AstraZeneca COVID trial in Kilifi, under KEMRI Kilifi. We've had close to 400 participants who've been going through this trial successfully, with no known, adverse effects in terms of the trial. And we're at that cusp where we are ready to roll out the vaccine deployment plan. And internally as a ministry, we've been able to, set up a team. I have with me today, Dr. Willis Akwale, who is chairing the vaccines deployment task force. And it's a team that consists of several experts, all sourced from, within the ministry and as well as private sector and different practitioners and stakeholders across the field. And this task force, has worked hand in hand with various other task forces that have been in place, particularly when it comes to vaccine introduction. I think for me, one of the things that I continue to celebrate about our country is that we've consistently done well when it comes to introducing vaccines. You're all aware of the HPV vaccine, the malaria vaccine, and other new childhood schedules that have been introduced over the years through the concerted efforts of members within the Ministry of Health and other stakeholders. And so COVID-19, while appreciating how magnanimous it is something that I'm well aware that Kenya will be able to do and to do it successfully. And of course, for us to be able to do that, one, yourselves as a resource that requires to be protected, need to collaborate with us. One, in being champions for the vaccine, but two, particularly the plan that we're about to share with you today, we really are encouraging in the chat. And I will be sitting to really look at all the questions and be very active on chat with you, for you to really look at our plan and critique it and, give it the critical review that it requires. Help us look at the points that we may have missed. draw for us, those things that perhaps may be unintended consequences, particularly as we plan to start engaging communities within the next 2 weeks. Dr. Akwale will be able to share with you the granular details. I've seen the questions coming in from KMA team, questions concerning what vaccine candidates will be in use. Will we use Astra? Will we use Moderna? Will we use Pfizer? Will we use everything? I think those are questions that Akwale will be able to answer for us. I've seen a very interesting question on the infrastructure when it comes to cold chain. And I can say already we are getting lots and lots of, should I say, innovative proposals from the public in terms of how we can ensure we have our cold chain maintained as we roll out these vaccines. Of course, the issue of safety is very crucial, and I'm happy we'll be able to share with you, particularly as the medics, how exactly do we, ensure the safety of the process, the safety of the vaccine itself, and most importantly, post-vaccination vigilance, a role that really, when I do remember being in the wards, is something that really we need to pay attention to, and we will require yourselves, particularly as we build the M&E framework, to be able to perform vigilance and surveillance activities post-vaccine administration. Of course, we'll also share with you the costs. We'll share with you some of the different, should I say, facilities or credit lines that we intend to use. We intend to carry out this in a very transparent and accountable manner, and we'll be able to share that with you. I think there's a very pertinent role of communities. I think, again, particularly drawing on lessons from the COVID-19 response, the role of the community, and here I mean Mwananchi and all those pieces that come together as a community are quite crucial. And so we'll also share with you our community plans. I think another key area is capacity building. I've seen lots of requests from healthcare workers, both in public and private sector, when it comes to the training. How shall we train our healthcare workers, those who are administering the vaccine, those who are doing post-vigilance for the vaccine? How are we going to train you all? How are we going to be able to marshal that workforce that we're going to execute this vaccine plan? So really the ministry here today is extremely excited to engage. I am particularly humbled and proud because I do consider myself part of you, despite having taken a sojourn into government and bureaucracies. So I'm really willing to answer all your questions, keep them coming, and let's have really honest discussions in terms of how this rollout will look like. So at this point, if you'll allow me, Dr. Were, I'd like to hand to Dr. Akwale. Willis Akwale is one of the new members within the Ministry of Health. He is the presidential advisor for the ALMA program. The ALMA program is a program in which our president, His Excellency Uhuru Kenyatta, is a patron. And essentially, it's a program that provides for high political leadership towards malaria. And so Willis joined us about 7 months ago and has been doing incredible work in supporting the malaria work in the country. I think those of you who follow the ministry may know that just 2 days ago, we did launch an End Malaria Council. And that's also his work that I think KMA should be interested in, because there'll be a change in terms of how we manage malaria in the country, particularly when it comes to investments by community and private sector participation. Willis Akwale was also appointed as the chair of the COVID Vaccines Deployment Task Force. And so he'll be able to take us through all that we've discussed today, and him and I, along with 2 other members, will be able to field your questions today. So I can see questions coming up. So Willis, get ready. I think I'll hand over to you now, Dr. Karibu.
Thank you, Madam Cass, and a good evening to everybody else and my dear colleagues from across the country. Yes, I see a very, very big attendance. I'm very happy because actually this was part of the plan of the task force to engage professional associations, to engage healthcare workers as much as possible prior to the introduction of the vaccine. So I'm going to take you through, let's see, am I able to control the next? Remove control. I want to go to the next. Might I stop here? is into this posture and remote control. No.
Click forward, Daktari. Are you able?
Yeah, I'm trying to click. Oh yeah, let's see.
Thank you.
All right, sorry.
Okay, okay. So in terms of a background, I'm going to give a background, and just to say that we all know Kenya has over 100,000 cases so far recorded and nearly 1,800 deaths. And that vaccination is very key, a very key intervention as an addition to all the other measures that are already in place and are being used to prevent the spread of COVID. Preliminary data from phase 3 trials of a number of the vaccines that we've considered have been found to be safe and effective, many of them with an efficacy of above 80%. So the National COVID Vaccine Task Force that I chair was formed towards the end of December. And our key mandate was to guide on the vaccine rollout. And to do that, the task force was divided into the following work streams. There's one that is dealing with regulation and safety monitoring. There's another one dealing with costing, financing, and resourcing. There's one that is dealing with planning and coordination, especially coordination with all stakeholders and coordination with the counties where most of the vaccinations will be occurring. There's another work stream that has been working on procurement and logistics. There's one that is supporting trainings and capacity building and the overall issue of human resource management. Another subcommittee is dealing with advocacy, communication, and aspects of community mobilization. And we have one that is dealing with data management, monitoring, and surveillance. So one of the first things we did was to review the vaccines and seek the opinion of the Kenya KENITAG, which is the Kenya Technical Advisory Group on Immunization, chaired by Professor Were. And they made a recommendation that deployment of vaccines, in particular those that will have been approved by a stringent regulatory authority and registered in Kenya, can be adopted for use in Kenya. And at that time, Pfizer and Moderna were the only ones that had been registered by WHO. AstraZeneca was just given interim approval last week. But just to say, there are so many other vaccines with different platforms where they have authorization in various countries, including the Sputnik, the CoronaVac, which is a Sinovac, and that one is an inactivated type. But really to mention that the nucleic-based platform has two, the Moderna and the Pfizer. But also to just mention, there's a lot of ongoing work. There are a lot of other vaccines that are coming up. And we are really looking at data and to see how many of them apply, especially to the COVAX mechanism run by Gavi. So we've come with a deployment plan. We've actually finalized it. It's just taken a bit long to finalize the editorials and formatting, but we are hoping that early next week, it will get the ministry approval and it can be shared by all. The deployment plan has also been costed to cost 34 billion Kenya shillings to support activities over a 30-month period. And during this time, it will cover a population of 30% of the Kenya's population. The budget will be split into two. Gavi is giving support for 20 billion, while the ministry, the government will provide 14 billion shillings. We are exploring engaging the Africa CDC mechanism, which has also come up with a mechanism where they have been able to secure doses of vaccines that also have approval by Gavi so that we can do an extra 10%. Here, what I need to emphasize, the Gavi support is a donation, so we don't really pay. When we buy worth 10 billion, they'll give us vaccines worth twice that. But the African CDC has proposed a mechanism that it's a little bit challenging to government in the sense that they want governments to pay money to an Africa Exim Bank. 15%, for example, the 8.8 billion, government has to pay 15% to an account, and then they are able to give you a credit to cover the rest, and you pay at a kind of an interest rate of between 5 and 6, which is very high. So we are still engaging. We are a little bit uncomfortable with that. Hopefully they will, it will be in compliance with the financial regulations in government before we proceed. Now, in terms of coordination, this is just showing you what I stated early, and we didn't replicate a lot of our responses, our coordination structures. The National Emergency Response Team has just been converted to also act as a steering committee during the vaccine deployment. In terms of county level, again, we know that there's a county response team co-chaired by the governor and the county commissioner, and we want that to act as a steering committee at the county level, but then come up with a specific vaccine deployment and vaccination task force to be chaired by the county director of health as the chairperson, and to involve cadres that are directly involved with vaccination, and then also to deal with those that will be dealing with resources, financial resources in particular, like the accountants at the lower level. At the sub-county level, we've proposed that the sub-county constitute a committee, not a task force, chaired by the sub-county medical officer of health, assisted by the public health nurse and the logisticians and disease surveillance officers, as we have again indicated there. So this is our conceptual framework for the vaccine introduction against the thematic areas that I mentioned, planning and coordination, where there are meetings of the National COVID Task Force and subcommittee workings, both at national and county level. In terms of vaccine selection, we consider issues of cold chain capacity assessment, the different scenarios of introduction, the selection of vaccines, their justifications and characteristics, and how we integrate this to the ongoing immunization programs by the National Vaccine Immunization Program. We look at how the vaccines are delivered and the overall issues to do with supply chain management, both before delivery into the country and upon receipt to the facilities. Then we are looking at the actual vaccination, and we are looking at population targeting. We've come up with how we'll use a phased approach, healthcare waste management, and monitoring of adverse reactions. And then finally, the whole issue of data capture and ensuring that this data is linked to the DHIS, and that we are able to do evaluations to see the impact of the vaccination as we roll out. So some key assumptions so that I tell you what we have planned. So if we are to plan to vaccinate 30% of the population, that translates to actually 15.8 million people, very close to 16. And we plan to do this in 3 phases, aligned to the government fiscal years. The vaccination will be rolled out to progressively cover all target groups based on vaccine availability. At the moment, there's quite a bit of challenge to get the vaccines. I can assure you, even up to today, I'd almost started giving up, but there are indications now and almost confirmation we'll get vaccine before the end of this month. The early vaccination will focus on administration sites that can reach prioritized population with as much throughput as possible. So we are looking at high level 4, level 5, level 6 facilities. This is where we want to begin as we roll out. Negative storage vaccines, and these are the nucleic ones. That is the Moderna, which requires -20, and Pfizer that requires -70. We are not going to consider them during phase 1, as we would want to improve on the infrastructure that we have to facilitate this. Although we have facilities that have -70, especially Kemri and the National Public Health Labs, these facilities are already storing other biologicals. So, and we don't want to mix vaccines with other biologicals. Individuals will need to receive at least 2 doses of vaccine during the rollout. And therefore, it will be very crucial that the ministry and the counties ensure that you hold on to a second dose reserve. We don't enter into what happened in the UK, where immediately the vaccines came, they gave them to more people, and when the second dose was due, they were not available. So our first approach, a little bit of it and timelines is as follows. In aligning to the government fiscal year, Q3 is actually January to March, and Q4 is April to June. Last week, the papers misinterpreted Q4 to mean December. That's where they got wrong. It was not the calendar year. Here in phase 1, when we still don't have adequate vaccines, we are going to target frontline healthcare workers and other essential workers in priority sectors. And our target population is 1.25 million people. In phase 2, starting July, we see more vaccines being available, and we'll therefore expand the priority groups to include persons above 50 years of age and those above 18 years living with comorbidities. And here our target will be very close to 10 million people over the financial year 21-22. While in the phase 3, which will be 22-23 financial year, our focus will go more towards those above 18 years living in congregate settings. These are prisons, these are refugee camps, and people who may be destitute and in homes. Now, let me actually say already, although this is our plan, some of the partners are coming and saying they can start supporting some of these disadvantaged groups by ensuring they procure the vaccines. Now, so this is giving a little bit of details on who the frontline healthcare workers are, and actually just to say everybody working in a health facility will be a frontline healthcare worker. We have been meeting several teams, and they have been asking why we don't include the relatives and spouses of healthcare workers. I must admit we have not done that at the moment, and a little bit because of just the amount of vaccines we may be getting to start with. Then the other critical services will be teaching and non-teaching staff in education institutions, uniformed forces, security forces, instructors in religious institutions. Now in phase 2, when we start covering those with comorbidities, especially those above 18, we'll be looking at people living with cancer, diabetes, chronic lung diseases, other neurological disorders. There's also been a lot of push from government that we bring forward the individuals working in hospitality and tourism industry as well. I think I've done that. So in terms of first approach, again, phase 1, we, as I said, will use level 4, 5, and 6 hospitals. Here we have determined that there may be about 284 government facilities and 195 private facilities. We are going to use private facilities to also administer the vaccine. We are working on those mechanisms. During phase 2, we will increase the number of government facilities, but also private facilities, and then gradually increase to almost 8,000 facilities offering this vaccination as we go to phase 3. And this is how people will be registered. So recipients are going to be registered for the vaccine in advance. So there's going to be a pre-registration. So that we know, are you really eligible as phase 1? And we are going to use the structures at sub-county level so that people are registered and this information is aggregated at sub-county level. Then vaccine distribution will be done to those facilities. Then scheduling and communication to recipients on the specific vaccine days and for specific vaccine sites. And then vaccine administration documentation of client and vaccine details will then be followed, issuing of a vaccine record and scheduling of the second dose. Now, let me say something before we go to capacity building, that we have developed a digital platform that is going to help us in the pre-registration and to capture data during vaccination and to be able to generate even a certificate when one requires. This has been done in very close collaboration with the Ministry of ICT. They did a demo yesterday, and it's very exciting that within 2 weeks they have actually come with what potentially will be an overall electronic vaccine register for Kenya. The reason we did that, we didn't want to take on any kind of vendor-based system because we are going to be capturing a lot of citizen-level data, personal data, and we wanted the government to be the custodian of that data. In terms of training, it will be a cascade approach. We are planning to start the training of national master trainers next week, actually. The curriculum has been developed. The training materials are actually almost ready. And then as we move to the county, we are going to have a blend of in-person training and virtual trainings that will be taking place. We are also going to encourage self-learning. We are hoping that we can host a number of the training material on the platform that we'll be using, but also now with the professional organization, we'll be asking them to host such material so that people can do as much self-learning as they can. So that in the end, we are hoping to train almost 23,000 healthcare workers within the coming 1 year. Now, communication is going to be very key. We already know there are issues to do with hesitancy. A study done in November last year indicated that there's almost 16% hesitancy to the vaccine. It could be higher. It also worries the task force that it could even be higher among healthcare workers. So one of the things we want to start doing is to inform members about the plans on the vaccine, as I'm doing today. We want to encourage and create demand for the vaccines in Kenya, sensitize as many stakeholders as possible. Today I met the Interfaith Council. Yes, they really made sure I lost all my saliva in the morning. I've just recovered. And we want to demonstrate that the government commitment to fight COVID-19 through also this appropriate deployment of the vaccine. So the way we'll go about communication is that we have just finalized a communication plan. We've also been developing some of the key messages that really try to address any concerns, a lot of which is about safety. We realize that there are a lot of misinformation and misconceptions about the vaccine. We've seen the social media and you can see people really talking and trying to convince the population. So one of our plan is that we'll develop key messages that can be used by as many stakeholders as possible so that we are consistent with the messages that we are passing. We will be glad to share these messages with any of the stakeholders that are keen to support this work. We are hoping that we can be holding media events that it's not only the government that is seen to be pushing for vaccination, but that at this media event, we'll have the minister with the religious leaders, with other politicians, with professional bodies, the leading professional colleagues, really addressing concerns together. One other thing is the issue of bulk messaging, especially as reminders and also just passing messages about the vaccines. We are budgeting for this so that we are able to deploy it. At community level, we consider the use of community champions, people who will champion for the vaccination, as very key, and that we would want to support them in terms of budget to be able to move within counties. Now, this is the Gantt chart of our plan. And just to clarify, I know in the media you've been, there used to be the talk of February. The truth of the matter, yes, the vaccine is going to very likely be here before end of February. And but our plan is that 2 weeks after it arrives, we begin the actual vaccination so that we have everything really set out. The COVAX mechanism today communicated that they are ready. If there are only 3 conditions we will be required to meet next week before they ship. The first one was to do with the local registration of the vaccine, which was done yesterday. The other one is to do with an import license, which is not a challenge. The third one, which may just delay, is to do with indemnity. And this is something where it's like the companies are absorbed as we roll out. And it's a discussion between the Ministry of Health, the National Treasury, Attorney General, and the manufacturers themselves. We engage them today so that we meet next week. We will need to submit that. And once that is submitted, then our orders will be shipped. Now, let me also say something before I go to the next. The issue of emergency use authorization, I need to state that these vaccines have emergency use authorization, but not market authorization. So they must be used within the public sector, and somebody will have to sign that they agree to use them, knowing that, yes, they have been approved, but they are willing to be vaccinated. The private sector had initially approached and requested that the government procures the vaccines for them, and they buy from us at cost. And although that was an initial kind of agreement, after second thoughts, we realized it could encourage pilferage from government facilities. So what the government has done is that it is discussing with the Pharmacy and Poisons Board to see if some of the frontline health buyers of pharmaceuticals can be given conditional market authorization so that they can start bringing some of these vaccines, but to be under very close monitoring by government. Now, this is just something, and I will not take much time here, is what we did with the counties, trying to ensure that we are able to map the vaccination points, the cold chain logistics. And just to mention, the slide is not here, but we have a central vaccine store is in Kitengela. It has negative temperature of -20, so we can deploy Moderna to a limited extent in the country. We can store it. The amount of vaccines that it can store is 20 million vials of vaccines. So basically, almost all the vaccines we require can be stored in Kitengela. However, we are very cautious that we should not interrupt the routine immunization of children. So we have to ensure that the supply chain is able to continue with the routine immunization even as we deploy the COVID vaccine. And one of the recommendations we've given to the counties is that the vaccination site should not be at the MCH. So they will have to identify somewhere far from MCH so that there's no crowding. Yeah, and I continue over here. Some of the things, the scheduling of vaccinations will be important so that, and crowd control, sending of reminders and defaulter tracing, ensuring safe storage, transportation, managing the logistics up to the last mile. We will designate specific individuals to manage information flow, including what goes to the media. And we want to ensure adherence to vaccine deployment through SOPs. So some of the challenges and discussion points that we've been having as a task force is how we will ensure we get the enumeration of providers by phase of vaccination from both public, private, the FBO and NGO, the registration of the vaccinees by phase of vaccination, the stakeholder and community engagement. It may vary from one county to another. How are we going to deal with vaccine supply challenges, especially when it comes to prioritization of target populations? And here what we consider is the fact that once the vaccines go to the county, much as this exercise is a national exercise, you may find politicians, governors may be deciding to change the priority populations to get other people vaccinated before others. So a lot of national discipline will be required here. Now, the issue of expanding the cold chain, especially as we approach phase 2 and 3, has been considered. We've asked government. Actually, we've submitted a request of about 1.45 billion Kenya shillings so that we expand the storage first at the facility level and also look at the introduction of ultra cold chain facilities. Monitoring and documentation of vaccination status of individuals and the tracking of vaccine stocks. The digital system that has been developed can actually track the vaccine stocks by batch numbers, but the vaccines, unfortunately, the vaccines themselves cannot be tracked because they do not have barcodes. So the country is going to barcode the batches, but not the vaccine itself. So some of the key actions, and this I'll not go, we have already asked counties to give us information that will help us to start populating, and we'll be going to the same counties in a week or two to do micro-planning. Thank you.
Thank you very much, Dr. Ahwale, for the insightful presentation. There are so many questions coming in, but I'll possibly let you maybe rest your saliva and drink some water as we invite other panelists to make their comments before we go to the actual question and answer session, which Dr. Kigondu will be leading. So without further ado, I'll be inviting Dr. Ombeva to make his comments, 3 minutes to make your comments regarding the presentation that has been made from an expert perspective, and so that you can continue. Thank you.
Thank you so much for this opportunity to be able to maybe just reflect. I should say that I'm quite impressed by the level of at least focus and effort that the government has gone ahead, the ministry, to put in place, and more importantly, the deliberate effort to engage stakeholders and especially healthcare workers. I do know that, like the presenter did mention, our biggest worry at the moment is hesitancy, both at the level of the healthcare workers and the community. But I think these efforts that are driving change, looking at the particular areas that is mentioned that are going to be engaged, my own personal view and opinion would be that maybe in the very initial stages, we may need to focus on targeting the healthcare workers first as we think about issues about hesitancy and uptake of the vaccine, than targeting the community. And even if we are thinking bulk messages, I think my view would be that we skew our approaches to the health workers first, because they are the ones who are targeted in phase 1. So it makes little sense to target the bigger community population if the ones you are going to immunize in the immediate term are healthcare workers. Deliberately and purposefully leveraged to looking at how do we loop all these healthcare workers into messages of encouragement. I do think that at this stage, beyond just KMA, we need to think about how do we bring in the associations. So we do have, say, for example, the Kenya Pediatric Association, we have the Gynecology Obstetricians Association, we have the physicians, the psychiatrists, the nurses, the laboratory technicians. I think those need to be looked in at this stage. One particular group that I've seen that has not gained adequate traction, and we need to think a bit more about that, is the medical students in clinical years, because these ones are actively involved in care of patients. So you're talking about mostly usually the 40 years and 50 years and maybe 60 years of the medicine group, and then you're looking at the nursing. Nursing, I think they start as early as third year and fourth year. So those form a critical mass of healthcare workers, and even those in MTCs, those doing laboratory and pharmacy, we need to seriously think about those, and also community health workers who ply their trade between the hospitals and the community. So it may be that I don't know that the target of 1.25 million is a fairly good target that may loop them in, because the medical students are not so many. If you really strictly think about it, we come to a total of about maybe 3,000, 4,000. But I think we'll actively need to think about how universities and these training institutions can be looked into to be able to bring that on board. And the other group that I'm a bit concerned about are healthcare workers who are in private sector. Let's say, for example, not necessarily hospitals, but private clinics. And I think a bit more thinking needs to go into how those will be looked in. Because if we do vaccinate them at the hospitals, there are some who don't come to the hospitals, but they do run their own private facilities, maybe say consultation clinics and things like those. And we need to rethink a little bit more how we can loop all that into the conveyor chain, so that at the end of phase 1, we should be pretty much confident that we've covered all the healthcare workers or people who interact with the patients. And so that's why I say the medical students in clinical years is something that we need to very, very clearly think about, and how we can loop them in, the nursing and medical students and laboratory, because they also come into very close contact with patients. I do support the thinking that people in hospitality areas need to be looked into a little earlier than putting them far, far towards the very tail end of the immunization program. And that is a thinking that I think we need to embrace, for the very reason that they interact with a lot of people. They are really almost like security guards, you know, and almost like first responders, where you're looking at firefighters. And because if someone is generally spends all his time in a hotel, and guests keep coming in from all sorts of areas, then that can become a very important person in terms of the spread of the disease. I want to reassure people that we do not need to be so worried about, because I've had quite a number of people concerned about the AstraZeneca vaccine vis-a-vis the resistant strains that we are seeing in South Africa, and which we know that are posing a major challenge to the vaccines, the effectiveness being very, very low. I do know that, and we all know that the UK strain has shown fair response, you know, a fairly good response. In fact, the thinking is that maybe eventually they may need a third dose of the Pfizer and Moderna vaccine to bridge any gap that will be there. But we still have a challenge with AstraZeneca, but that is in South Africa. We do not have that strain circulating locally. And our local studies, including the work going on in Kilifi, is showing a lot of promise. So I think we need to build confidence in the AstraZeneca vaccine on two fronts. One, that we do not yet have a significant circulating strains in our country, so we can take that. Two, for the very reason of cost, the AstraZeneca vaccine is fairly affordable for our circumstances and situation. And especially now that we do have the COVAX and the African Union arrangements to get us that vaccine. And thirdly, for the purpose that there are those people who've been claiming that the DNA and mRNA vaccines may affect people's DNA. And I know a lot of anti-vax groups are using that reason. But suffice it to say that the AstraZeneca vaccine does not take that approach of manufacture. It's made from putting the spike, the DNA coding messaging, the messaging for the cells to produce the immunity against the virus onto the adenovirus, the chimpanzee adenovirus. So that means that this is a technology that has been used and tried severally for other vaccines. So that should help us gain strength in terms of advocating for uptake of the vaccine, especially that particular line by the anti-vaxxers. So thank you so much.
Thank you, Dr. Ombeva, for encouraging us and the public regarding the safety of the vaccines, and pretty much talking about vaccine hesitancy. Dr. Gikonyo from the Nairobi Hospital, We are privileged to have you today, coming in with a voice from private sector, having supported the government and the COVID-19 pandemic. Possibly from your end, from the comments that have been made, would you like to make a few comments on the plans that the government have and how you can plug in?
Yeah, thank you very much indeed for the invitation and for enabling me to be here. First of all, we need to commend the Ministry for Health for a very, very good plan that they have actually made in connection with vaccinations, and even overall for the COVID health education program that has rolled out since the very beginning. Kenya's program has actually been highly commended around the world, and Kenya has enjoyed considerable success in terms of the public health control of this illness, and I want to encourage them to continue that good work. We are very, very impressed with their, program to roll out the vaccine, and we believe that this program will go well. Generally, vaccination around the world has been a big challenge. It's been a challenge in America, it's been a challenge in Europe, it's been a challenge around the world. Challenges have come from the availability of the vaccines. Challenges have come from storage, like the Pfizer vaccines, which require very cold storage. So these challenges should not discourage us. They are common to all mankind and every part of the world, and we should face them positively and work at them and see what we are actually able to do. In the private sector, we have been very keen to have the vaccines available. We have been talking to the ministry and even to the Poisons Board, and we are happy to hear that AstraZeneca has now got the necessary approvals. We're also very happy to hear that the ministry is encouraging the Pharmacy and Poisons Board to allow even the private sector to actually import, store, and administer these vaccines, and that in their program, they're actually going to also involve both the public and the private hospitals. And that is really key because all of us belong to one community, to one nation. And if you vaccinate one sector and you leave the other one out, you will not solve the problem. So we need to move together as healthcare workers through the ministry and in collaboration with the private sector so that we end up with the best possible outcome. Of course, there are issues of vaccine hesitancy, but our position is that we should vaccinate those who are willing to be vaccinated, especially now that the vaccines is not so readily available. But over time, then it will be possible to vaccinate and also help, educate others so that they can also participate in that particular aspect. One of the things which we as private sector are already starting to look at is testing the variants that are there in our environment so that if there are any changes, we will get to know this. And we also encourage the ministry to also test for variants because this time it may be a South African variant or a Kent, UK variant, but in future, there could even be a Kenyan variant. So we need to keep on testing these variants so that we can always respond to them. But I think I want to commend the ministry and even the private sector and encourage all of us to work together. And in this manner, I'm sure we are going to keep ahead of the virus, keep it under control, and eventually overcome it. Thank you very much. Back to you, Elizabeth.
Okay, thank you so much, Dr. Gikonyo. And we're glad that the private sector is also keenly looking as to how to support to improve the capacity of government in the vaccine rollout. Dr. Lois Umbajo, before I invite Dr. Eva Jenga to make her comments, possibly from an expert perspective, what are some of the things that from the presentation you've picked up you'd want to emphasize or maybe pose questions to?
Many thanks, Dr. Gitau, and thank you, Dr. Kwale, for that presentation. I think it's taken a lot of work to put that together. We commend the committee for really looking at so many different aspects because there's so many moving parts in getting this together. So we really commend you for the work that you have done so far. So I think there are many questions that have been asked in this forum and again by many people across the country about this issue of this AstraZeneca vaccine. So one, I think we probably need to understand that there needs to be caution when we are comparing these reports of vaccine efficacy, remembering that many of the studies looking at the vaccines have been done in different populations, have looked at different different endpoints of, definition of disease, for example. So if you look at this AstraZeneca vaccine in view of the South African data, basically what they reported to us and what they have at least published in the paper that they've just recently released as a preprint is that when they looked at mild to moderate COVID-19 caused by the variant, then the vaccine had very little efficacy. And here we have to pause and think of what again is the essence of vaccination. Is it to prevent mild disease? Is it to prevent transmission? Is it to prevent severe disease and mortality? And often probably the best endpoint would be looking at severe disease, hospitalization and mortality. And unfortunately from this South African work, they did not really have sufficient numbers to tell us about how well it prevented severe disease and how well it prevented mortality. The Janssen vaccine has been touted as a possible better option because there's a little data looking at, moderate disease as well as severe disease. So again, we really can't directly compare all the vaccine trials given because they use slightly different endpoints. Having said that, there seems to be some confidence that even with the AstraZeneca, it may still go a long way into preventing severe disease and mortality. And for that reason, those who have access to it should not hesitate in rolling it out even as we wait for better options. Having said that, however, I think I have a question for Dr. Akwale that he could comment on. And really it's about how well we can adapt to changing circumstances. We may already have a large order of AstraZeneca, for example, but as more data comes available, how adaptable is a national plan in terms of being able to quickly order new vaccines as they become available for the country to buy? Because as there's so much data and there's so much studies going on, so things are going to be changing rapidly. So how adaptable are we? Also, are there any plans regarding the Janssen vaccine? Not so much just because of efficacy, but because of the issue of using a single dose, which would be much easier for a country to deploy as opposed to one that would require repeat dosing. When it comes to the issues of the Moderna vaccine coming in fast, we really have to think about not just the availability of storage at the airport or at some terminal, but how then do we get it to Turkana, for example? How do we make sure that healthcare workers in far-flung areas get it? Issues of transport and even storage at those sites really have to come in. I think we really have to talk to people about issues of accepting vaccination, because the more of us who get vaccinated, the better it is for the country in terms of achieving some level of herd immunity, so to speak. The issues of continuing to constantly conduct surveillance for this variant is really important. As you know, our borders are not exactly foolproof. We have a lot of travel in and out of the country. We see a lot of the Southern African countries being ravaged by the new variant, and there's always a trace that we could get more of that variant, and surveillance sometimes doesn't necessarily pick it at the point of entry. So we have to be increasingly vigilant, increasingly be watching out for any new spikes or clusters of infection that need to be investigated urgently. I think I'll stop there and maybe answer any questions that may come up. Thank you so much.
All right. Thank you, Dr. Lois. And I'm informed Dr. Mercy Mwangangi may be having to leave shortly, but I will give this opportunity to Dr. Eva Jenga of the Kenya Medical Practitioner Dentist Council to give her comments so that Dr. Mercy can summarize before she goes away.
Thank you, Elizabeth. And let me first say thank you to KMA for putting this forum together. I wish to thank Dr. Mercy Mwangangi for accepting our invitation to come and give the information that we so badly need as the medical fraternity. And Dr. Willis, honestly, that your presentation has answered so many questions that are already on the Q&A platform and even on the chat forum. So I think that was really well done. Now, as from the point of the regulators, I think there's one or two things maybe I want to highlight. Dr. Akwale, said that you will be using biometric for registration for people to be vaccinated. I'm thinking at this point in time, you mentioned that we have several registered health facilities. We also do have that data already digitally of all the facilities in the country that are licensed. You may have 14,000 facilities that are registered, but only about 5,192 that actually are licensed. So we need to, I think we need now to liaise with your committee so that you get the facilities that you need to be reaching out for biometric registration for the vaccination. Two, just remember that all the doctors and are registered, any practicing both private, as Dr. Obeba rightly said, that we must consider also our colleagues in the private sector who may not be reached within the hospital facilities. We have all those doctors registered under the Medical Council and Dental Council. So the Medical and Dentist Council. So I think it will be prudent to make sure that we get this registration data, and it's there, it's actually on the website, that we make sure we utilize that so that we don't miss out on it. And we have both our local practitioners and even foreign practitioners. The same thing goes with the Nursing Council of Kenya, the clinical officers, and all the other frontline health workers that we need. At this point in time, I was going to one question I have for Dr. Willis. As we are thinking about the frontline workers, we have people we are taking care of at home for home isolation. And a number of our health workers that are going out there are these voluntary health workers. Those is a group that's honestly, I don't think is registered at any platform. So I think we need to come up with a strategy to make sure that we don't miss out these volunteers who go out into the community, especially for home care, and to make sure that they also get cover early. And I think these are some of the things that the various bodies, whether they are the professional bodies, whether they are the regulators, must work together with the vaccination task force so that we make sure all the frontline health workers are covered as early as possible. I know, having talked to Dr. Mwagagi earlier, that we are expecting like 4 million doses to be coming in the next 2 weeks or so. You talked about having storage areas in Kitegera. You talked about the -20. I know we have some Visa doses coming in. Do we have storage facilities at -70? And even as Lois asked, and I think it's Obeba who said, how do we move that vaccine now to the health facilities? That cold chain, how secure and how foolproof is it to make sure that by the time these vaccines are getting to the people that are targeted, they are still effective and efficient? So I think it's, as you have answered, Dr. Akwale, you have answered most of the questions in your presentation. Mercy, I think there are many more questions that will continue to come up your way. My suggestion from the Medical Council is that we make this information an update regular, whether it will be through KMA, whether it will be just directly from MOH. We make this platform and webinar on updates on the vaccine from the National Vaccination Task Force. We make it regular so that we don't have people asking questions. And you can see how many the questions are. If we had this even earlier on, I think people would be a bit more settled. But I must applaud the Ministry of Health. I know that last 1 year has been tough, but I think we really are on top of things and we are doing the right thing. So congratulations to all of us, both in the private and public sector and the Ministry of Health. And KMA, please, let's keep on educating our colleagues about the vaccine and the use, so that this hesitancy that we have, and it will continue. It's not only just in Kenya, even in the developed countries. I know so many people who have brought in the conspiracy theories about why we shouldn't get the vaccine. But I think it's important. We have the disease monitoring specialists like Lois. Please keep coming to people and telling us who really needs to get this vaccine. Talking from a private practitioners, we have many clinics that take care of people with cancer, people, even the hospice. We have many people who take care of people with the comorbidities. We need to know, and you can ask that, get the data from the council so that we know that these groups will not be missed out. So I think that I'll stop there because I know Mercy has to go, but we'll continue listening and hopefully addressing any other concern that might be answered by the regulators. Thank you so much.
Thank you, Dr. Eva, for your continued support and wisdom sharing at most of our meetings. We appreciate you. Dr. Mercy Mungangi, even as I'm told that you need to leave, possibly you can, some of the questions that you have picked up from the various questions that have been asked by the panelists and in the chat box, possibly you can give your final remarks, taking note of some of the maybe questions or concerns that have been asked. Are we going to be charged for this vaccine? Is it free? And number two, will the government ministry officials and the government in general be sort of the first ones to take the vaccine as a show of solidarity and also to prevent vaccine hesitancy? Thank you.
Thank you, Daktari, and thank you to Dr. Eva Njenga and all other panelists really for your contributions today. I've been looking through the questions and trying to take a stab at some of them, and we encourage you to continue posting them. We have the team from the ministry who are curating all the questions, and we shall be able to send back responses to the KMA team in terms of answering the questions. I want to perhaps support the suggestion by Dr. Eva Njenga that we need to make this regular. I think we also, during the COVID-19 response, we had regular interactions and engagements. And so Dr. Kigondo and team, I'm hoping we'll be able to put in place some form of mechanism where we can update each other, and particularly when we start implementation, because things will arise and things will change. So we'll need that platform where we can come together, share experiences, share learnings, and course correct. In terms of the vaccine cost as it stands today, the discussion is that the vaccine will be free in public facilities. And the idea is, this is one of the mechanisms of ensuring that, we ensure that we're reducing as much hesitancy as possible. And of course, most importantly, ensuring that there's equality in access to this vaccine. There are discussions to ensure that, when the private sector comes to engage and participate, that there will be a mechanism of regulating costs, even at the private sector, because that does have an effect also in terms of, public sector reception of the vaccines. When it comes to the receiving of the vaccines, that's a very interesting question that you ask. Yesterday, I actually had lunch with the president and I challenged him, that we need to be ready to support the reception of the vaccines to ensure that, we combat hesitancy. And so as an individual, I'll be on the front line. I'll be there to receive the vaccine when it is made available. But it becomes important, and we are learning particularly from different countries, that how you engage and how you participate in this space sometimes can have unintended consequences. And so what we are doing as part of our risk communication, as part of our community engagement, really is to ensure that the Kenyan citizen receives the vaccine while having all information at hand. So I've seen lots of questions on, is this vaccine voluntary? Will I be victimized if I'm a healthcare worker and I don't want to receive the vaccine? Of course not. And so the idea is that you will make informed choices, much like the same way we conduct procedures and ensure that our clients have informed consent. We intend to really provide all the information for it to be available. I've already received tons of questions, even before today's engagement, from mothers who are pregnant, who are asking us, can I get the vaccine? Again, remember COVID, a new disease, the jury is still out on that. As you know, actually none have conducted trials in pregnant women, so we don't know. Although some countries are actually giving advisories. If you go to the NHS vaccines website, CDC, they are asking mothers to, make an informed choice and decide for themselves, and they quote trials in rats where they say, pregnant rats, had no ill effects or adverse effects in terms of vaccine safety. And so there's a lot of unknowns. There are many unknowns, and really what we can do in terms of just, keeping our eye on the goal is to, one, identify these unknowns, and try and wait for the information to be clear. And of course, provide as much information as possible so there's always informed consent as we move forward. Like I said, we've curated the many questions. The team, the task force remains available to you. You can engage Dr. Willis Akwale for any additional questions and his team. We will be coming back to you, most importantly, in terms of now rollout. Like we've said, we have a coordination work stream who will be coordinating with yourselves. I've seen questions about how do we reach our diabetics, hypertensives. Of course, that's where you come in as practitioners, as alliances. How do we get those people who have those comorbid conditions? And we know that it's not just the diabetes and hypertension, there are many others. So let's use this as an opportunity, perhaps as a medical fraternity, to restructure perhaps our health system when it comes to getting some of these key priority populations and rolling out this vaccine initiative. We do remain available. My office remains available for any further engagements that you may have. We're always there to support these processes, to support you and the country, of course. So at this point, I request to be excused. I'm actually in another meeting. So if I can perhaps take a bow at this point, I'd appreciate. And I think Gitao and Kigondo and her team can always reach out to us. We're available to all of you. Thank you.
Thank you so much, Dr. Mercy Mwangangi, for your continued support, and we appreciate the ministry honoring our invitation, and we'll continue making further requests to your team to support the association with information and the advocacy role. Thank you very much. Dr. Kigondo, over to you on the Q&A. Dr. Kigondo, you're here with us?
Thank you very much, Dr. Elizabeth. The questions are many, and with the time limitation of a few more minutes, like 10, we will take some questions that we think are heavy and direct them maybe to our panelists, one each, and then we can compile all the other questions, and as has been guided by the chair of the Kenya Medical Practitioners and Dentists Council, we will organize more webinars. So a lot of questions have come from the private sector, and a big question from one of the panelists, and maybe Dr. Mbira can take that, is will you allow private sector to import the vaccine as well as to improve coverage of the vaccine sooner? Both Dr. Willis and Dr. Mbira can take that, because that is a heavy one. It's a heavy one.
Dr. Kigondo, before Dr. Mbira responds, Dr. Lois Mbajo, infectious disease expert, who was one of our panelists, might have to leave as well. So if there are any technical questions, possibly you can share with them before Dr. Willis comes in.
Okay, I think Dr. Gikonyo can take that as we get one technical one for Lois, and then she can give.
Okay, yes. Generally, we certainly, as a private sector, are looking forward to having the vaccines, available both in those hospitals and to our patients, and of course to our health workers. The Ministry of Health is also keen, from what they have said, to make sure that we actually are able to get the vaccines in place. And I believe both will actually play a good role. But the best thing the ministry has said today is they're going to authorize a Pharmacy and Poisons Board to allow the private sector to actually import the vaccines, store the vaccines, and distribute them to their workers and to their patients. And with that, it will be a lot easier. So I believe this open kind of platform and forum, even in terms of vaccine distribution and allocation, is really what is going to make a big difference, and I believe it will go well.
Let me quickly add something. about that. Now, one of the things we need to know about the cost of the vaccine, they actually range from $32 to $38, so about 4,000 Kenya shillings per dose. So 2 doses will be like 8,000 Kenya shillings. Now, under the COVAX mechanism, which is a subsidy, the cost of all vaccines that are registered under it are $7, so about 770 shillings. So you can already see, even as the private sector comes in, there will be that cost differentiation. Now, the very initial doses the government gets, we want to actually pass them through the private sector as well. The discussion we've been having is how much will private sector charge? And we want to ensure that it is standardized. Among the recommendation is like a 200 shilling administration fee, so that people can easily access that in the private sector. But one of the concerning issues coming is a number of the private sector teams that we've met, not necessarily medical people, have started insisting that they would have to start doing antibody testing before vaccination. That is really not anything we want to recommend. And for us, we see that that may be an opportunity to exploit patients who may go for vaccine, but they are told to do a whole battery of tests. Over.
Dr. Kigodu, please, can I just ask Lois a question before she leaves?
Yes. Go ahead, Dr. Eva.
And this is actually in follow-up with what Dr. Willis has said about antibodies. I have quite a number of patients, my diabetic patients who have had COVID and pulled through, and they're asking me this very important question: will I need vaccination? And I have had the COVID. And since we know very few of the patients who recovered from COVID have actually raised any considerable or appreciable antibodies, Lois, what would you answer? How would you answer these patients? Or what would you tell the population that's recovered from COVID about a vaccination?
Many thanks, Dr. Eva. That's an important question that I think a lot of people are also asking. And maybe one of the reference documents that we can share, the WHO has a number of guidance documents that people can look up about even populations that need to be vaccinated. So I think one of the guiding principles, is that after someone gets infected, they may have some antibody response that tends to wane over time, which means it's not very clear how much longer it will continue to be protective. For that reason, even those who have had the virus before will require to be vaccinated. One of the things that I guess may be considered is that if you had 2 people and one has had the virus and one hasn't, then maybe you could vaccinate the one who hasn't had the virus before the one who's had the virus. But having the virus before does not preclude vaccination. For the diabetic population specifically, these are the patients who, at least in our population, have been at highest risk for most severe outcomes. I would encourage that they get vaccinated irrespective of, when they had this, when they had their COVID-19. So I think the message out there is that even those who've had the virus should still get vaccinated. The only question maybe for the rollout team would be the timing of that vaccination. Would you prioritize the diabetics who haven't had the virus just before because they're at highest risk, then still vaccinate those who had the virus? I hope that's helpful.
Yeah, thank you, Lois. That's really has answered my question, and I know I can pass that info to my patients and also to the general population. Thank you.
Thank you, Dr. Lois, for joining us. We appreciate your continued support, and I'm sure we shall be reaching out to continue this conversation on vaccination. So, Dr. Willis, there's a question regarding one criteria for selection of private facilities. How do you go about choosing what private facility that shall be chosen to offer the vaccine? And secondly, how have we prepared healthcare workers to vaccinate? Are there any trainings that have gone on already in terms of improving their skills and capacity?
Yeah, thank you. Thank you for that. Let me start with the last one about the preparation. So it's been very busy for us because we started most of the work beginning of January. We did the deployment plan. After that, we started working on the operational guidelines. I was happy today when I found that the operational guidelines are now actually done. So over this weekend, there's a team that is working on the training content. And our plan is that next week, a day like today, we should be conducting the training or concluding the training of national master trainers, and then moving down to the counties the week that follows. And then from there now, try to see how we quickly scale that up. So let me say training is about to begin, most likely next week. And yeah, just in time as the vaccines arrive at the end of the month, so that within 2 weeks of their delivery, we are able to start vaccination. Now, how will we identify the private sector? From this discussion, I'm happy that Dr. Ivan Jeng has told us they know where they are, because engaging some of the groups within the private sector, it started becoming a bit confusing. And for us, we had now requested the sub-counties. I know Nairobi can be a bit complicated, but within sub-counties that the healthcare workers provide with us a list of especially facilities that have high attendance, that see many patients, to be included. And that decision, we were leaving it to really the sub-county team. But from now, what I'm getting, if we can get a database of the active registered ones, that will do. Of course, the challenge will be there are also other facilities run by other cadres. So yeah, it's something we'll have to think through best. And especially determining like how many, which are the, because we are not going to start on a full scale. You can see we have limited doses, so we'll really have to make decisions as to the most strategically placed private facilities to offer the vaccination. Over.
There's one question that Dr. Ombeva, you may take. So, someone has said that please be brutally honest on the side effects. Brutally honest. That's how the question has been framed, Dr. Ombeva.
Okay, so I think everything we've said today, we've been honest and as brutal as we could. Just before I answer that question, I need to say something very, very briefly about the pregnant women. The guidance of CDC at the moment is that if you have a pregnant woman who falls in the category of the phase where they are supposed to be in the immunization, then the phase takes precedence. So let's say you're immunizing healthcare workers, and these healthcare workers get substantial exposure. So for the reason that the pregnant mother or expectant mother continues to work in the health facility, then they are guided to be able to take the vaccine. It's important to know that Pfizer has now commissioned a bridging study for COVID-19 in pregnant mothers and in children. So we'll know soon enough. But of course, that can't stop even children going to school. So pregnant mothers should be guided that if they feel comfortable, they should be able to get the vaccine. In terms of people who suffered the disease, I need to mention that if you've suffered the disease, you will still need to get the vaccine for the reason that the disease has not been able to raise adequate correlates of protection like what the vaccine has done in most of the people, at least the few that have been studied so far. So it's advisable that if you suffered COVID, and especially people who suffered earlier before we had very good testing, they still need to get the vaccine. So my suggestion would be that if someone falls in the category, let's say a healthcare worker, whether they suffered the disease or not, let them get the vaccine. And it would be confusing if we begin to stratify them, that you had the disease, so you get later. Let's just say the way it's been presented, they all go ahead and get their vaccine, and there's no need for pre-testing. So antibody tests, all those pre-testing should just be done away with, and we try and move the group so that we also save time and not introduce a lot of confusion. Okay, having said that, I need to mention that with these vaccines, just like any other vaccine, do have some side effects, but they are bearable. They are not any different from the other ones that we know from the other vaccines. So you'll have a bit of pain at the injection site, a bit of swelling, a bit of malaise for the first day or so, at up to about 24 hours of a bit of malaise and tiredness or something like that, and not in all people, just in some people. The concern will be people with allergic reactions. But I think that you can have conversations with the person giving you the vaccine if you do have those worries and fears. But that is as honest as it can be. So there's nothing untoward, no worries of death, no worries of modifying the DNA, no worries of causing infertility or making people sterile, all those things, causing teratogenicity. Those fears are not there at the moment.
Thank you, Dr. Ombeva. Before I hand over to Dr. Kigondu, maybe as a point to note is that on the question and answer forum, for those who put in their question, Dr. Mwangangi and the MOH team have been very kind and they're answering you even as you type in. So that is why we might not address all the questions live, but we have noted the ones which have been answered. Thank you very much, Dr. Mwangangi. The ones which have not been answered, for sure, we shall continue this conversation as we go ahead. And I really want to thank Dr. Were, our president, for actually initiating this kind of conversation. And I'm sure as we go along, we're going to have more conversation regarding the vaccine. Dr. Kigondu.
Dr. Ombeva, again, they are reported, Dr. Kizito Lubano asked whether there are the reported variants already in Kenya and how are the variants likely to impact on the choice of vaccination. He quotes a case example of South Africa, which switched to Johnson & Johnson vaccine, halting the AstraZeneca one. What is your comment on that? I know you've touched on it before, but I think you can repeat it for the general public.
Yeah, I think for our confidence, we need to know that Kenya and actually all other countries have activated active mechanisms for genotyping as much as they can, all the viruses that they're able to identify. And the most important thing is that at least that is not a big worry for Kenya now. But we know there's a lot of mobility and people move a lot. So as we move forward, I think that is something that is constantly being evaluated. There were suspects, but I wouldn't go into so much details of those cases. They suffice it to say that all of that has been contained for now. And what we know is that we are safe enough to give AstraZeneca for our populations. South Africa, I know they've had the shift because remember, that is their predominant strain. So you are saying that about 98% of all people have that particular strain, which is showing very poor performances of anything between 10 and 25% effectiveness. So that is quite poor.
Yeah, and just to add, if I may, that the budget we have at the ministry, we are very adaptable. We are not stuck to AstraZeneca, but there will be the initial introductory. In fact, the government has made available funds that we can decide which other vaccine we are able to procure. The Pfizer team, through the Africa CDC, is saying they can transport in minor special storage facilities at -70 to Nairobi and major capital cities. So, but we are yet to really finalize discussions on that. And then to also just, people should know that the Johnson & Johnson, the biggest, is produced actually in South Africa. And you must start reading a little bit of trade issues here. So South Africa wanted to use what they produce. And they are determined also to really penetrate in the other African countries. Over.
Real politic. There's a huge question from our Facebook viewers, whereby there's a comment that United Arab Emirates could vaccinate 5 million people in 1 month. So they are trying to compare your estimation of vaccinating 1.2 million in 6 months. Could you make a comment on that, Dr. Willis Akwale?
Yeah, thank you for that question. Absolutely a valid question. But again, my task force was very honest with itself that the biggest driver of our vaccination will be availability of resources. It depended on how much money the government gives us, but also how much vaccines we are just able to get. But as I've said, our faces are a lot more for guidance in terms of ensuring we have resources and that we have a structured way of introducing the deployment. But as more vaccines become available and as the infrastructure is put in place, we are definitely going to ramp up. It is not going to be easy when we first engage the county government. The good deployment plan I've presented here, it could easily be misinterpreted all over the place and we go into a lot of confusion. So we want to begin small so that we come onto the same page with the county governments, and that then as we scale up, there are a lot of lessons that will be learned as we move. There's also the danger of trying to rush. Even in the US, you realize they reached a point where the vaccines were in the store, but they were not vaccinating people. So there's a lot that you have to be strategic to create the demand. As I said early, the expiry period is very short. We could bring 5 million doses here, but in 2 months we have only 2 million, and the expiry of 3 million doses would be a very big scandal. So a lot of that considerations have been taken. Considerations have been considered. Over.
Thank you very much, Dr. Kwale, for that. Through our viewers on social media, on Facebook, and through the Zoom platform, we have received a myriad of questions, and we see that our webinar time of 1.5 hours is coming to a close. As advised, Kenya Medical Association has committed to organize a continuation of these Zoom webinars, especially on COVID vaccination, and also through our clinical COVID webinars. We will continue educating both the public and the health workers on the issues on COVID and keep people abreast on that. With that, I want to call upon the Assistant Secretary General of Kenya Medical Association, Dr. Diana Marion, to close the session. And we have promised to collate all the questions and put them in written form to answer them, and also organize other webinars for the same. Thank you very much. Dr. Diana, please give your last words and close the session for us.
All right. Thank you, team. Thank you, everyone. Thank you, representatives from the Ministry of Health. Thank you, representatives from the Kenya Medical Association. Thank you, all our other healthcare stakeholders. We really appreciate this. And this has been quite enlightening, and we've actually been able to pick out some of the challenges that we might need to face during this phase of trying to get vaccinations to our populace. And what we would like to put forward is that would advise that probably these are meetings we need to have a bit more frequently. This meeting has almost clearly put it out that going forward, we need to have these discussions more often. So I would urge our partners from the Ministry of Health, our partners from the various stakeholders, that we can also try to find a way to have these discussions a bit often. The reason being, when you look at the panel of questions, we have so many questions that we've not been able to answer today based on the time limit. So we probably might provide this in our future endeavors. Now, I am very proud to participate in this, and I'm really trying to hope that our Ministry of Health will try to push this agenda that most of the people that are frontline health workers or frontline in terms of exposure to the COVID-19 will be able to get these vaccines a bit faster, such that this tends to really help in terms of calming down the population. We're looking at it that it might be quite affordable and easy, even for the ones that in future might want to get this from the private sector. It's something to think about, to the point that you do not want to really wait in line, but if possible, you can pay for it. Let it not be something you have to really sacrifice so much for. Otherwise, I want to really thank every person that presented in the panelist panel. I also want to be very, very grateful to the people that attended this meeting. I want to really appreciate the fact that you spare your time to see what is the way forward when it comes to the COVID-19 pandemic in Kenya. And we hope going forward that our partnerships are going to be quite fruitful. And we hope that we are going to overcome this. Somehow we will be able to overcome this. Thank you.
Thank you so much, Dr. Marion, and thank you to our healthcare workers and to the public and all those who joined us tonight. It has been an excellent, excellent session. We have learned a lot. And I really want to thank the KMA National Executive for also giving me this chance to host the meeting and also for continuing to the front regarding this COVID-19 pandemic. And we shall continue to advocate for better care for health workers and also for the public. Thank you very much. Dr. Kigondu, close the meeting.
And with that, I think we can call it a day. We will announce when the next meeting is and invite all of you via the social media platforms and the KMA website. Good night and have wear a mask, wash your hands with soap and water, and keep safe. Thank you very much.
Thank you, Dr. Kigondu, Elizabeth.
Thank you, Kigondu. Yes.
Thank you, Dr.
Good
Kware.
night.
Good night.
Good night.
Thank you, everyone. Good night.
Good night,
Hi,
everyone.
Dr. President, Mr. President.
Bye.
All right.
Bye.